Thank you, Chairman, and thank you very much for inviting me to this wonderful international conference. My name is Makoto Amaki from National Cardiovascular Center, located in Osaka. My talk is not about the conduction disturbance or EP area, but I'm specializing in structural heart and heart failure. So I broadened up this topic to what is the best option for treatment of tricuspid regurgitation. So my talk is about the anatomy of the tricuspid valve, severity of TR, classification of TR, and treatment of TR. So I think most of the people are familiar with the mitral valve, but not familiar with the tricuspid valve, or probably EP doctors are familiar with the right ventricle or right atrium, but valvular heart disease doctors are not familiar with the tricuspid valve, so we go through the anatomy first. Tricuspid valve is consisted with the three valves, obviously, but the septal leaflet, and anterior leaflet, and posterior leaflet. And the annulus is very important for the tricuspid valve because it dilates after the right ventricle remodeling in a heart failure patient. And also, these annular dilatation creates the tricuspid regurgitation, so that the surgeon would try to minimize this annular diameter by the surgery. Important point in tricuspid valve is the papillary muscle. There's a two papillary muscle, anterior papillary muscle and a posterior papillary muscle. And the anterior papillary muscle is very important because it is the marker to differentiate the anterior leaflet and the posterior leaflet. This is the type of the TR differentiated by the TEE. And people will think that the tricuspid valve only consists of the three leaflet, but actually it is very multiple. Some patients do have more than three, or some patients do have a two leaflet. Notice that the major type is type 1, but the second major type is type 3B, which consists of 4 leaflet. Mostly posterior leaflet is divided into 2. In a real actual TE image, you don't, the TE image does not show where is the border of the posterior leaflet and anterior leaflet. And by looking at the papillary muscle, anterior papillary muscle, you would also able to differentiate the anterior papillary muscle and posterior papillary muscle, as shown in this diagram. Next, let's move on to the severity of the TR. There is a new criteria for severity of TR. Conventionally, it's 3 grade with mild, moderate, and severe, but recently it has expanded to massive and torrential. This is very complicated, so you don't have to remember this, all the numbers, but it is very important to know that these grades are important after the intervention because a lot of patients do come up with a massive or torrential TR. If the conventional measurements say only severe, then after the treatment, patient maybe end up with a severe TR, but the starting point may be a massive or torrential, which means that the degree has changed 1 or 2 grades in the TR. So that is very important. Also, the timing of the grading TR is important. This is a 65-year-old male with a leg edema. As you can see, a patient has a severe MR, and he had atrial fibrillation. We did cardioversion to this patient, and a few days later, the TR went away. So the timing is very important to grade the TR. Next is the classification of the TR. The classification is a primary TR and secondary TR, and majority of the patient is secondary TR. Primary TR includes the myxomas change, pacemaker related TR, infective endocarditis, and the congenital heart disease and traumatic and rheumatic. But these are only up to 25%, and most of the TR is a secondary, which is left heart disease, and RV dysfunction, and pulmonary hypertension, and right atrial abnormality due to atrial fibrillation. This is one of the study that's seen in real life cohort of 103,000 page exam, and look at the severe TR was consisted in 2% of the patient. And when we look into this, the etiology of the TR, notice that the secondary TR was around 70%. Primary TR was only 6%, and the rest is mainly with idiopathic TR with atrial fibrillation. With the high-age society these days, including Korea and Japan, atrial fibrillation incidence is increasing. So I think these idiopathic TR would be more prevalent in the near future. So lastly, let's go into the treatment, the surgical and the percutaneous treatment. The surgical treatment for TR is a conventional treatment. It has increased recently from the early 2000 to recently. The number of the TAP and TVR is increasing. However, when you look at the 30-day in-hospital mortality is about 8.8, which is about around 10%. Out of 10% die after the surgery. Well, this is because the right ventricle failure do exist in these patients, but notice that there's a really high risk of surgery. So most of the patient or cardiologists do not want their patient to send to the surgery. But in the guideline, it says that there's a clear classification, high classification if when the patient goes to left heart surgery. If the patient have a severe TR and go to the left heart surgery, it is class 1 indication. Even moderate TR, it's 2A. And even mild TR with the RV dilatation, it's still 2A to 2B. So patient who goes to the left heart surgery, we should think about intervening TR. So, but should we recommend the surgery to patients who have a less than moderate TR and have TAP? This is the one RCT, small number size, but who was scheduled for mitral valve surgery, and a patient who has less than moderate, and annulus size is enlarged more than 4 centimeters. And look at after the follow-up for 1 year, and see how the TR worsened. And obviously, patient who did the annuloplasty remained less than the mild, shown in the dark gray. But notice that in the gray, the TR worsened after a year with no annuloplasty, and all these patients were less than moderate at the beginning. So especially in the rheumatic heart disease patient, they exacerbate after a period. So those patients who have a dilated annulus, more than 4 centimeters, even the TR is less than moderate, they should do the TAP. But the valve morphology is very hard to define, and also the severity of TR is very dynamic. If the patient comes up with a congestion, the tricuspid annulus can be nearly 5 centimeters, but if you treat with the dialytics, it can be less than 40. So again, the dynamic of this morphology and TR severity is diverse, and we have to treat well and then assess the TR severity. What about the repair versus replacement? We all know that in mitral valve space, replacement is much better than repair is much better than a replacement. But what about in tricuspid valve surgery? In tricuspid surgery, isolate tricuspid surgery and also the concomitant tricuspid surgery at LV surgery, all-cause mortality, readmission incidence was better in a repair group. But is this true? A lot of patients do have a RV dilatation, and those patients tend to go to the replacement. So there might be patient selection misleading. So we have to be very careful about choosing which to choose. Lastly, I would like to introduce the transcatheter treatment for tricuspid regurgitation. There's a two major device, the mitral TriClip, which is close to the mitral clip, and also the Evoke, which is a valve replacement. There's other devices coming, but I think these two are the most widely used, and I think it will be coming to the Asia near future. TriClip is the majority of the device that has been used in Europe and US, and that is converted in the mitral clip to the tricuspid device. The size is quite similar. Size is absolutely similar to the mitral clip, and the device is quite similar. There's a prospective randomized trial called TriLuminate trial that has been published in New England Journal of Medicine, and this is similar to the co-op trial, tricuspid valve, tricuspid device, TriClip device versus the medical therapy. Unfortunately, the hard endpoint, the heart failure and survival rate did not improve with this TriClip device. However, obviously the TR severity was reduced. Less than moderate is nearly 90%. And also KCCQ improved in a patient who has moderate or less after the treatment. And notice that the reduction of the TR, if the patient has no change or worsened, there's not much increase in KCCQ. However, if the patient do have a 1 grade or 2 grade, additional the effect can be seen in the improvement in KCCQ. And this is the point where you notice that the 5 grade, the torrential and the massive, is important to have the effect on the KCCQ. And also 2-year outcome has also proven, and in this paper, there is improved not only the quality of life, but also the lower rate of the heart failure hospitalization, and also the mortality was better in moderate to, or less patient after the TriClip treatment than severe or more. Who will be the candidate for the TriClip? The unsuitable patient can be seen. For instance, the calcification, leaflet coaptation gap is enlarged, or the congenital heart disease. What about the RV lead interference cases? It can be treated with the TriClip if the valve is not attached to the lead, but sometimes it is attached to the lead, and that is creating the tricuspid regurgitation. And for that kind of patient, it could be treated, but the long-term outcome is not very promising. Anatomical suitable cases is shown here. No pacemaker lead, not too much gap on the leaflet, and the location of the tricuspid regurgitation in septal and anterior leaflet as shown here. And this is very ideal case for TriClip. Lastly, there's a tricuspid valve replacement therapy, and Evoke, produced by the Edwards, is the device that has been also waiting to come in Asia. And we have done this TriScent trial in Japan as well. We have done 10 cases in our institution. The device catches the subvalvular apparatus by this anchor. And also, we implant the bulky valve into this valve, and so that the anchor and the valve sandwiches and release the anchor there. And this is the actual device therapy images. You can see, and you can see it's very bulky. The downside of this therapy is that it creates the conduction abnormality. About 10% of the patient do have a conduction abnormality, and 10% of patients do have to have a pacemaker lead. And to place the pacemaker lead is another concern, is that we cannot place the lead implantation to this, through this device. So we have to put the leadless pacemaker. So, but the tricuspid regurgitation is absolutely amazing, and the reduction of the heart failure hospitalization can be seen in a prospective single-arm study. Lastly, what kind of the structural heart disease treatment should be chosen according to the anatomy? Most of the patients can be treated with a TEER, but some patients with an enlarged or CID-related patient, it has to be TTVR. So take-home message is this. Thank you very much.